and systemic sclerosis is relatively easy to diagnose on clinical grounds, but polymyositis and dermatitis will be much difficult to diagnose for you people. Now, our objectives of this lecture to enhance your competency to recognize these diseases on clinical grounds. How to investigate, the second objective would be, and the third, to know the basic drugs in management. Scleroderma. Scleroderma basically is a Greek word. The word scleroderma means derma pertaining to the skin, and sclero means thickening and indulation of the skin, or hardening and indulation of the skin. This is what systemic sclerosis or scleroderma means. It is basically a multi-system disorder characterized by functional and structural abnormalities of the blood vessels, fibrosis of the skin and internal organs, immune system activation, and autoimmunity. Epidemiology, prevalence is very, very low. It's very difficult, in fact, to know about the exact prevalence of this disease. 4 to 12 new cases per million per year have been recognized. Susceptibility host factor, age peak occurrence is 35 to 65 years, that is middle to old age group. Now, as in other connective tissue and rheumatological disease, there is always female preponderance for some reasons which are really unclear. Here again, the female ratio is more than the male to be affected, that is 3 into 12 females per 1 male affected. Now, there is most of the time genetic background in this disease. Now, let's go to the types of scleroderma. Basically, scleroderma are divided into 2 types, that is localized scleroderma and systemic scleroderma or systemic sclerosis. Now, in medicine, there are basically 2 terms, systemic sclerosis and one is multiple sclerosis. Now, don't confuse these 2 terms because systemic sclerosis is basically a connective tissue disorder which is affecting the skin and the deeper tissues. And multiple sclerosis is basically a neurodegenerative disorder of the CNS and peripheral nerves. So never confuse these 2 terms, that is systemic sclerosis and multiple sclerosis. Anyhow, now localized scleroderma is again further divided into 2 main types, that is morphea and linear scleroderma. Morphea basically affecting the particular area of the body. Linear scleroderma in which hardening of the skin is in band-like fashion. And systemic sclerosis into 3 terms, that is limited scleroderma, diffuse scleroderma, and the silent scleroderma. Now, limited and diffuse systemic sclerosis of skin involvement. Here you see limited sclerosis, only the face, neck is mainly affected, as well as the distal extremities. Proximal are usually spayed. The trunk is spayed, and here again the legs are affected. This is in limited scleroderma or limited systemic sclerosis. In diffuse, almost the whole body is involved. Almost the whole body is involved in diffuse scleroderma. Now, as far as prognosis is concerned, limited scleroderma has lately a better prognosis as compared to diffuse one. Because the diffuse one, not only the skin is affected, but also the viscera, they may be affected. Different viscera or different internal organs may get affected, and it usually have serious prognosis. Again, here the same thing, diffuse cutaneous, limited cutaneous, and overlap syndrome. Now, the word overlap syndrome, basically, we are using this word overlap syndrome when the systemic sclerosis is sharing features of some other connective disorders. Say like, if suppose the systemic sclerosis, there is xerostomia or xerophthalmia, suggestive of Sjogren's syndrome. Systemic sclerosis having malar flash, which could be suggestive of this SLE, or systemic sclerosis may have severe joint pains, which could think us about this rheumatoid arthritis, that in this condition we are using the word overlap syndrome. Clinically, there is sharing of different clinical features of both diseases in overlap syndrome. Now, there is one more disease, what we call as mixed connective tissue disease. Mixed connective tissue disease is basically a bit different from the overlap syndrome. In overlap syndrome, usually the two diseases, they are overlapping with each other. In mixed connective tissue disease, we usually have three or four diseases, say like systemic sclerosis, polymyositis and dermatomyositis, rheumatoid arthritis, sometimes SMEs like this. So this is three or four diseases associated with typically increased levels of anti-RNP, that is ribonucleoprotein levels in MCTD. This is not our topic right now. We're just confined to here with this overlap syndrome. Now, localized scleroderma is morphia and linear scleroderma. Now, what happens in diffuse cutaneous systemic sclerosis? That is proximal skin thickening, distal and proximal extremities, and often the trunk and face. Almost the whole body, the skin is affected. Tendency to rapid progression of the skin change, rapid onset of the disease following Raynaud's phenomena, and early appearance of visceral involvement and poor prognosis. So here there is poor prognosis of this diffuse systemic sclerosis, and there is a relative early appearance of visceral involvement. Limited, we have symmetric restricted fibrosis affecting the distal extremities along with face and neck. Long delay in the appearance of distinctive internal manifestations and prominence of calcinosis and telangiectasia. Now, this limited cutaneous SS is relatively having good prognosis. Now, there is one more term, that is the CREST syndrome. Now, this could be an exam question for you, CREST syndrome. What actually CREST means, there is calcinosis, calcium deposition, Raynaud's phenomena, in which there is change in the skin color from pink, white to blue, esophageal dysmotility, sclerodactyl, and telangiectasias, multiple hemorrhages in the body. Now, this is constellation of this CREST syndrome: calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyl, and telangiectasia. Now, CREST syndrome is basically sometimes is used in the sense of this limited cutaneous systemic sclerosis. More or less the same meaning, that is CREST syndrome or limited scleroderma. Overlap syndromes, features of systemic sclerosis together with those of at least one other autoimmune rheumatic disease, that is SLE, RA, that is rheumatoid arthritis, or polymyositis. Any one of these may be sharing with the basic diagnosis of systemic sclerosis. A bit difficult to diagnose clinically. Pathogenesis now. Susceptible host, some exogenous events. Some exogenous events may be some viral infections, immune system activation, fibroblast activation, and endothelial cell activation. That is both vascular damage as well as fibroblast activation ultimately lead to the end-stage pathology of obliterative vasculopathy fibrosis. Now here, basically the epidermis and dermis is involved. Vasculopathy is there, leading to loss of vessels, loss of blood supply, causing this thickening and hardening of the skin. Now, clinical features. Vascular abnormalities, they are most important. It is Raynaud's phenomena, cold hands and feet, reversible skin color changes from white to blue to red, induced by cold temperature or emotional stress. Somebody is putting his hands, will not be having any features suggestive of systemic sclerosis. Now, this person sometimes comes to you with complaint of, doctor, whenever washing my hands, whenever I put my hands in cold water, I get some numbness, I get some soreness or pain, and when the color of the skin changes and it gets a bit white to dusky. The most important diagnosis is Raynaud's phenomena. Now, this is Raynaud's phenomena. This Raynaud's phenomena may be either primary or maybe secondary. Primary Raynaud's phenomena when there is no underlying disease, some genetic susceptibility. Secondary Raynaud's phenomena, it may be secondary to systemic sclerosis, may be secondary to some other connective tissue disease, in Sjogren's syndrome, in MCTD, in polymyositis, and dermatomyositis. But most commonly, this phenomena is observed in systemic sclerosis, that is diffuse systemic sclerosis, Raynaud's phenomena. Now, this is the initial complaint in 3/4 of the patient. Now, this is very important. Initial complaint in 3/4 of the patients. Every 3 patients out of 4 complain of this pain, numbness of these extremities and color changes. 90% of in patients with skin changes. The systemic sclerosis usually come across with skin changes. So most of the time, the symptom of Raynaud's phenomena is there. The only thing is to ask about this to your patient and to recognize this. Now, digital ischemic injuries. Now here you see Raynaud's phenomena. These are the relatively pink fingers, whiteness, and finally they turn into cyanotic. Telangiectasias. Here you see multiple hemorrhagic spots, capillary dilatation, not only on the face, but also inside the tongue. It is blanchable, blanched by pressure. Here again, telangiectasia, multiple inside the lips, inside the mouth. Here you see, and over the face, distributed in a random fashion over the face. Here again, telangiectasias, perimeral telangiectasias are there at the nail foot, capillaries are dilated here. Now, clinical features of skin. The first thing was of vascular involvement, the second, skin involvement. The skin involvement basically occur in 3 stages. Stage 1, skin get edematous, non-pitting edema. Non-pitting edema. The most important definition of non-pitting edema in medicine is obviously we think of some sort of lymphatic obstruction, or sometimes you may encounter in patients with hypothyroidism, that is non-pitting edema. But here we usually overlook our patient, and we usually misdiagnose our patients of systemic sclerosis at relatively early stage when there are no obvious skin manifestations. So here the skin starts with edematous phase and then indurative and atrophic phase. The second is firm, thickened, bound to the underlying soft tissues. The skin is very thickened out. It is height bound. Number 3, decrease in the range of motion, loss of facial expressions. If you ask your patient for the forehead, he'll be unable. If you ask the patient to make the creases over the forehead, he'll be unable to do so. And inability to open the mouth fully, and there may be contractures, extensor tendon contractures will be there. Now, inability to open the mouth, that is microstomia, usually seen in patients who are chronic bitter eaters, or those who are using this sort of thing like gutkhas and others, difficulty in open the mouth. But in these cases, the cause is usually submucosal fibrosis inside, which hampers to open the mouth adequately. This is one of the very, very important symptoms, a very important sign of systemic sclerosis here. Now see here, edematous face, sausage-shaped fingers are there, bilateral. Here, skin induration, thickening of the skin. It is very difficult now at this stage to pinch a skin fold here, because this skin now has been hardened up. This skin now has been fused with the underlying dermis and underlying tissues. Acrosclerosis. Here again, you see extensive induration leading to contracture-like deformities and very tough, very hard skins, like just, you see, sort of, really like woody hands. These are the woody hands. Here, facial changes, the very classical faces of systemic sclerosis. Microstomia. Here, if you see, vertical brows are there, vertical ridges are there, just below the nose. Loss of facial expressions, no ridges at all over the forehead, beak-shaped nose. This is very, very classical for this systemic sclerosis. Once you see these patients, you are never to forget in your whole life. And it is very easy on clinical grounds to diagnose this systemic sclerosis. Here again, you see the same thing. The skin is very tightened up. It is bound to the underlying tissues. Here, a patch of alopecia, which could be again a feature of systemic sclerosis. Alopecia usually we see in patients with SLE, but here alopecia is also could be due to sclerosis. Here again. Now here you see there is thick skin of the forearms, proximal scleroderma. Very difficult to raise the skin, to make the skin folds here. It's a normal skin over here. You can easily differentiate these two. Morphia. Now, this is a form of localized scleroderma. Any site of the body may be affected. Here, the skin and this patchy distribution, morphia. This is thickening of the skin. Here. The skin involvement finally lead to ulceration, loss of soft tissues of the fingertips, pigmentation, calcific deposits, and capillary change. And musculoskeletal system, polyarthritis and flexion contractions will ideally last. Muscle weakness and atrophy. Now here you see digital ulcers at the tip of the finger. Digital ulcers, which is evidence of the vasculopathy, evidence of the vascular disease. Here again, you see here this small digital infarcts are there. Skin is very tightened up. And here again, you see the same things. Digital ulcers are there and multiple punctate hemorrhages are there. Here, loss, self-amputation of the tips of the fingers, self-amputation, digital necrosis. The whole half of this digit has been lost. Here again, the digit has been lost. The digit has been lost. This is all secondary to the systemic sclerosis. Now, you see, if you get this type of picture, the differentials, the systemic sclerosis, the most important, another differential could be leprosy. Patients with leprosy could have findings like this. Here again, the same thing. The very advanced form of systemic sclerosis and multiple here you see whitish patch. This whitish patch are nothing but the calcium deposition, that is calcinosis. Again, there is calcinosis, calcium deposition over the fingers. Now acrolysis, that is lysis of the bones, lysis of the tuft of the fingers. The whole distal part of this digit has been lost secondary to this. Now it involves from the skin and it goes down. The pathology goes down into the bones now. So there is destruction of the peripheral part of these digits. Here again, fitting scars. Crest syndrome, this is calcinosis cutis. The word calcinosis cutis is pertaining to the skin. Calcinosis means calcium deposition. That is here. You see there is calcium deposition inside. It is very similar to that of Tophaceous gout. Tophi sometimes they may be same here. But these are not very characteristic places for the tophi to be deposited in this earlobe. Here, calcific deposits are there. This is calcinosis cutis. Nail foot capillary abnormalities. Here, telangiectatic spots. Here you see this is the normal nail foot. Now here you see these are the multiple hemorrhagic spots. Sometimes very easy to overlook these things, but with a special focus and attention, you can easily identify this with nail foot capillary abnormalities. Calcinosis and acrolysis. This is the X-ray of the hand. Multiple calcium deposition. Plaques of calcium are deposited throughout, and this is the bone has been lost here, almost all 3 fingers. Now, diffuse systemic sclerosis, as we have discussed previously, it's not only limited to the skin and the deeper tissues, but it also involves the internal or visceral organs. The most important here is the GIT involvement in the form of esophagus, stomach, small intestine, and the large intestine. Almost whole of the GIT has been involved. In esophagus, there is hypomotility and retroesternal pain. It usually affects the distal third part of the esophagus, that is the smooth muscle of the esophagus, causing fibrosis, difficulty of relaxation, which ultimately leads to the reflux esophagitis and a stricture formation. Stomach delayed emptying. There will be delayed emptying in the esophagus, in the stomach. The small intestine pseudo-obstruction. Patient may complain of repeated constipation, sometimes with diarrhea, diverticulitis, malabsorption, ultimately lead to the weight loss and severe cachexia. Weight loss and severe cachexia. Diverticuli, very important this here to be formed in small as well as in large intestine. Again, large intestine, chronic constipation and fecal infection with diverticuli formation. Now here diverticuli, you can see here, diverticuli in this X-ray, small outpouchings of mucosa and submucosa here, multiple diverticuli of this transverse colon. Here again, outpouchings, you can easily recognize this, outpouchings. Multiple outpouchings are there, mimic diverticuli, and there is diffuse dilatation of this part of colon, diffuse dilatation, and there is holdup of barium here. Now, how the kidney really reacts with this disease, diffuse scleroderma in association with rapid progression of skin involvement. Now, kidney is really very important organ to be affected in this disease, and it usually entails and it makes the bad prognosis of this disease. Pathology, what happens? That is intimal hyperplasia of the interlobular artery and phrenoid necrosis of the afferent arterioles leading to glomerular sclerosis. The whole glomeruli of both the sides, they get sclerosed. How to present in the form of proteinuria, abnormal urinary sediment, azotemia that is rise in the creatinine, microangiopathic hemolytic anemia, microangiopathy Jones or helmet cells to be there in the peripheral blood. Patient would have this anemia and renal failure ultimately. Now, this renal failure is really very important reason for the patient's increased mortality once the kidney gets affected in diffuse systemic sclerosis. Lungs, they are also involved in the form of shortness of breath. Now here, what you see here, this is very mimicking nowadays with that of COVID lung. COVID, if you see nowadays, this COVID is there. If you see the X-rays of advanced coronavirus, you may have a similar picture. Multiple reticulonodular densities here, multiple interstitial infiltrates here. They start right from the base. They go gradually up and involve almost whole of the lung area on both the sides. Now, this is very interstitial lung disease or restrictive lung disease, which is very, very typical of systemic sclerosis. Ultimately, it leads to the right heart failure and pulmonary hypertension. All diffusing capacities will be low in this patient. Now, this is again one of the important reasons for increased patient's mortality. Decreased oxygenation and carbon dioxide increase in the blood. Heart. In heart, usually systemic sources of effects with pericarditis, heart failures, arrhythmias, and conduction defects, and myocardial fibrosis leading to MIs. Exocrine glands sometimes gets affected. They may be pure, the solely feature of systemic sclerosis and nothing to have with this Sjogren's syndrome. Exocrine glands like xerostomia and xerophthalmia, that is dryness of the mouth and dryness of the eyes. Now, second thing, the second objective. Now, clinically, you see, it's not, once you get such patients with, I have seen personally, a few cases, say like 5 to 6 cases throughout in my career of this systemic sclerosis. If you want to see more cases, I think they are basically being presented in the Department of Dermatology, systemic sclerosis patients. And you may come across patients with systemic, very easy on clinical grounds. I think there is no difficulty unless and until there is a limited sort of disease. In limited form of the disease is very, very difficult. But once the face is affected, then I think once you would see such patients with big nose and a small mouth, you will never forget. And it's very easy for you to diagnose it. There are certain clinical laboratory parameters in which you may be more confident to say that you are dealing most likely with a patient with systemic sclerosis. Now here you see AN. AN is present in more than 90%, 90 to 95% of the patients with systemic sclerosis, that is anti-nuclear antibodies. And this is rheumatoid factor. It is again present in 40 or 50% of the patients with systemic sclerosis. But this presence of rheumatoid factor has nothing to do with the clinical features of systemic. That is, it won't cause rheumatoid arthritis. And very typical way in which the rheumatoid arthritis usually works, though there may be some arthralgias and non-erosive arthritis and systemic sclerosis also. In rheumatoid arthritis, the RF is usually seen in 70% of the patients, but here 30 to 40% of the patients rheumatoid factor. Anti-SCL70. Now, this is very specific test for systemic sclerosis, but it is seen in not more than 40%, maybe 30 to 40% in diffuse and 10 to 50% in limited scleroderma. Anti-centromere antibody, it is present in up to 50% and sometimes maybe more than this in limited scleroderma and 5% in diffuse scleroderma. So if you are having this ANA, I think this would be quite sufficient for you people on clinical grounds to label your patient is having systemic sclerosis. You want to make sure more, then you have to do this anti-SCL70 because anti-SCL70 portends a bad prognosis, more diffuse involvement, more internal organ involvement, and a worse prognosis once the patient is having anti-SCL70. So this is important from prognostic point of view. This is anti-SCL70. Now, diagnosis, major and the minor criteria. Now, this is really not very important. One major criteria or two or more minor criteria for the diagnosis. Major criteria like proximal scleroderma. Proximal scleroderma means the fingers, the face and neck. Minor criteria may be sclerodactyl, digital pitting scars, or loss of substance from the finger pads, and bibasilar pulmonary fibrosis. Bibasilar pulmonary fibrosis is an interstitial lung disease associated with this. One major or two more minor criteria will suffice for you to make the diagnosis of systemic sclerosis. The most important, I think, here, you just see the sclerodactyl and typical skin changes, and this. Now, treatment, bit difficult. The treatment of this disease is not steroid. Now, this is exam question. The treatment of this disease is not steroid. Treatment usually depends on the system involved. Wide spectrum clinical manifestation, severity, spontaneous improvements occur frequently, and you have to tailor your treatment according to the symptoms. It is mainly symptomatic. Disease-modifying drugs are there, like penicillamine, methotrexate, immunosuppressive agents like cyclosporine, or interferon gamma, and recombinant human relaxant. But the most important here is the symptomatic and organ-specific treatment of systemic sclerosis. Now let's see how the Raynaud's phenomenon usually gets resolved. The most important is to avoid cold exposure. Layers of warm and loose-fitting clothing must be used by the patient. Now educate the patient to use the loose-fitting clothing and avoid cold. Quit smoking. This is very important because smoking in the peripheral digits, peripheral circulation causes the vasoconstriction. Vasodilator therapy in the form of calcium channel blockers, that is nifedipine. You can use it long-acting 10 to 30 milligram per day. Prazosin again in the form of, this is also antihypertensive. Prazosin, Minipres, they are all vasodilators. You can use prostaglandins here and other drugs like PDF inhibitors, like phosphodiesterase inhibitors like sildenafil, that is Viagra or Viagra-like drugs, very effective in abolishing this Raynaud's phenomenon. And if there is finger or toe necrosis, you can use intravenous prostaglandins or amputation. The only thing is do the amputation here. Now you see with all these drugs, but still the problem would be there unless and until you don't have to avoid cold exposure, because it usually gets worse with cold. It usually gets worse with this sort of emotional stress. So you have to have a good counseling with your patients to avoid this cold and emotional stresses. Now, gastrointestinal reflux, esophagitis, and dysphagia usually is being treated by elevation of the head of the bed, small frequent meals, and never take meals 3 to 4 hours before you have to take the last meal at least 3 to 4 hours before your retirement, before you're sleeping. You have to avoid caffeine containing diuretics because this will all lead to the spasm of the Cigarette smoking, you should have avoid this. And for drugs, H2 blockers and proton pump inhibitors. Proton pump inhibitors are very, very effective, and it will nullify the acidity inside the stomach and avoid the esophagitis. It is very important complication of this systemic sclerosis. 20 to 40 milligram you have to give for at least 4 to 6 weeks, proton pump inhibitor. Gastroparesis, because there is delayed gastric emptying, so gastroparesis is a big problem for your patients. They may have multiple constipations, frequent constipations or diarrhea, or alternative constipations or diarrhea. So you have to use a pro-motility agent like metoclopramide. Malabsorption syndrome is there because there is dilatation inside the intestine. Pseudo-obstruction will be there. Bacterial overgrowth will be there. You have to use broad-spectrum antibiotics in the form of either tetracyclines or in the form of quinolones. Renal crisis. Renal crisis is very sort of worst thing once the patient have this in systemic sclerosis. It's really worse. The early detection is very, very important in renal crisis. And AC inhibitor is the drug of choice. The drug which usually used traditionally is captopril. 25 milligram captopril you can use frequently, at least 4 to 6 hours. Or you can increase the dose 50 to 100 milligram, 6 hours. 1 year survival without captopril is just 15%. So you can here see that without this renal intervention, the survival has been decreased. That is only 15%. And 1 year survival with captopril is 76%. It's a lot of difference. You see, there's a lot of difference here just by using the drug. And once you recognize the renal crisis in the form of severe malignant hypertension, in the form of proteinuria, in the form of abnormal urine sediment, increased urea and creatinine, they all lead to this. And once the renal failure is really not effective with this sort of things, then you have to go for dialysis. Now, overlap syndromes, features of systemic sclerosis together with those of at least one other autoimmune rheumatic disease, like SLE, rheumatoid arthritis, or polymyositis. The scleroderma overlap with rheumatoid arthritis suggests distinct features of diffuse scleroderma with positive SCL70, pulmonary fibrosis, and later seropositive erosive rheumatoid arthritis. Now, one thing which is really very important, erosiveness of these joints are very, very peculiar pathognomic of rheumatoid arthritis. But if you are getting this sort of arthritis in pure systemic sclerosis, then it is mainly non-erosive. Now, this is very important to recognize. Now, prognosis is quite variable. 5 years in diffuse, it is 70%, and in limited, it is 90%. And 10 years survival rate is 50% in diffuse and 70% in limited. So you see here that this diffuse has got much more this mortality rate. The major cause of death is the renal involvement, cardiac involvement, and pulmonary involvement. Now, if you are going to somebody, if you are using this steroids can be used in this disease, but only when there is features of some other conditions. Say like sometimes the arthritis is more troublesome, or myositis may be more troublesome, myalgias may be more troublesome, but never exceed the dose of steroids to more than 15 milligram, because this will precipitate this renal involvement. And once the patient is going to renal crisis, that is very, very difficult to revive back from this condition. So steroids are basically not the drug of choice to treat this systemic sclerosis patients. So this was all about the systemic sclerosis. The most important thing to diagnose in systemic sclerosis is to see and to look and to focus and concentrate on the skin changes. Number one, very important, typical faces of this systemic sclerosis, involvement of the other organs, and ANA and anti-SCL70 from lab. And as far as management is concerned, manage the symptoms. The most important is to manage the symptoms and manage the organs as such. And you can use here the drugs like disease-modifying drugs like methotrexate, azathioprine, cyclophosphamide if the lungs are mainly involved, or sometimes mycophenolate. Now, this is the second topic what we have to uh, do here. Polymyositis. Now, polymyositis is chronic inflammatory myopathy, a persistent inflammatory muscle disease that causes weakness of the skeletal muscles, which control movement. Weakness of the skeletal muscles. Now, here, the proximal skeletal muscles are mainly involved. If you are seeing a patient in which distal muscles are predominant involved in the proximal, then you have to revise your diagnosis of polymyositis. Now, in fact, truly speaking, polymyositis is more difficult clinically to diagnose as compared to sclerosis. Medically, polymyositis is classified as chronic inflammatory myopathy. It can occur at any age. Adults usually 30s, 40s, or 50s. Again, here the women are more affected as compared to male population. It is more likely seen in black people. Signs and symptoms usually develop gradually over the weeks or months, and remission is rare. Now here, to go into the definition, heterogeneous group characterized by proximal muscle weakness, involvement of the shoulder and pelvic girdles. Classification, adult polymyositis. The word polymyositis means myositis only is there. That is, only muscles are involved. Adult dermatomyositis. Now here, the skin is involved as well as the muscles are involved. Dermatomyositis. Number 3, myositis associated with malignancy, usually seen in older age group patients, usually seen in male or female both, and childhood myositis in children. Again, here the muscles are mainly involved. Myositis associated with systemic autoimmune disease, that is overlap syndrome and other inclusion body or eosinophilic myositis. Now, inclusion body myositis is the most important differential of this polymyositis, most important. Signs and symptoms. It appears gradually, progressive muscle weakness, difficulty in swallowing. Now here, as compared to the systemic sclerosis, where the distal esophagus, distal 1/3 of the esophagus involved, here the proximal striatal muscle of the esophagus is involved. That is difficulty in swallowing, dysphagia and odinophagia. That is pain on swallowing will be there. Difficulty in speaking, again here, dysphonia, muscles of the speech are affected. Mild joint or muscle tenderness, fatigue, and shortness of breath. Now here the important thing is, the patient usually don't complain of muscular pain, no muscle pain. The disease is myositis, that is inflammation of the muscles. But surprisingly, the pain is absent or minimal. The most important symptom is weakness, inability to climb the stairs, inability to lift up from the seated position from a chair, inability to comb the hairs, inability to lift both the arms above the level of the shoulder or to pick something above the level of the shoulders. That is proximal muscle weakness. Again, difficulty in walking. So this is very important. But there are a lot of differentials of this muscle weakness. This could be due to muscles purely, or it may be secondary to some neurogenic weakness in the form of upper motor neuron or in the form of lower motor neuron weakness. So this is very, very important to differentiate polymyositis from those conditions in which basically the nerves are involved. Say like in conditions like motor neuron disease, say like in conditions like multiple sclerosis, and other conditions in differential diagnosis. What we usually have is the myasthenia gravis. Many drugs, they are causing this muscle weakness, like steroids themselves, which is very important in the therapy. But it also causes the muscle weakness. Statins, frequently used with dyslipidemia and hyperlipidemia, causes muscle weakness. Again, the other drugs like chloroquines, like Acigure, hydroxychloroquines, they all cause muscle weakness. Clofebrate, they all cause muscle weakness. So this has to be differentiated from polymyositis, which is relatively a rare disease as compared to other things. Dysphagia leading to weight loss and malnutrition, aspiration pneumonia, shortness of breath, or respiratory failure. Finally, the respiratory failure is second due to the diaphragmatic involvement. Calcinosis. Again, calcinosis would be there in polymyositis, and calcium deposits in the muscles, in the skin, and the connective tissue. In multiple sclerosis, there was calcinosis, but there was no muscle weakness. It was principally affecting the skin, but here the calcinosis associated with muscle weakness, that is polymyositis. Now, diagnostic criteria are the proximal muscle weakness, proximal motor weakness. Symmetric proximal muscles will be involved bilaterally. It may be unilateral at the start. To start with, say, like left arm is more affected than the right one, but with the passage of time, both the arms get affected. High serum muscle enzymes level, that is CPK, aldolase, myoglobin, SGOT, SGPT, and LPPT. Now, these are basically the enzymes what we interpret in LFTs. The altered these liver enzymes will be there. In SGOT, SGPT, they will be there. But CPK will be more this important in diagnosing this high serum polymyositis. CPK normal value may be up to 300. It increased more than 5 times, or sometimes even 50 times, more than the 50 times normal value. CPK is very important. And then aldolase. Aldolase is basically a bit costly test. We usually avoid this. But to diagnose it with confidence, it should be done, both CPK and aldolase. Now, here how are you going to define? The most important second step in the investigation is to do myography, EMG and NCVs, electromyography, and nerve conduction studies, nerve conduction velocities. In patients who are having this polymyositis or dermatomyositis, very typical EMG pattern of polyphasic action potentials, short duration, and low amplitude action potentials will be there. In neuropathic disorders, which also cause muscle weakness, there will be polyphasic action potentials with long duration and large amplitude. Now, this is very, very important. You don't have to forget this thing. It is very important. So EMG is of paramount importance in making the diagnosis, in making to differentiate muscular weakness, whether it is of purely of muscle origin or no, it is of neuropathic origin. Now, NCVs, that is nerve conduction velocities, are absolutely normal nerve conduction velocities. But here, NCVs will be delayed latencies, abnormal NCVs, nerve conduction velocities will be abnormal. Muscle biopsy. Muscle biopsy is usually biopsy of clinically weak muscle contralateral to an abnormal muscle, MRI detected. MRI we usually do to see the changes inside the muscles, and some of the people, they are doing muscle MRI before proceeding to muscle biopsy to exactly locate the abnormal muscle groups before going to biopsy. Now, one thing really very important in a muscle group which has been gone with this EMG should never be biopsized, should never, because it would give you a false positive result. So you have to choose another muscle. You have to choose other muscle groups whom this EMG was not done, where EMG is not done. Perivascular endomysial inflammation would be there, the prominence of the lymphocytes, CD cells, perivascular and endomysial inflammation. And number B, muscle fiber necrosis and regeneration, muscle fiber necrosis. Now, at the start of the lecture, we have seen about inclusion body myositis. Inclusion body myositis is a very, very important differential of polymyositis, inclusion body myositis. Inclusion body myositis, so far I've seen just a single case of inclusion myositis in my prior practice. Usually the males are affected, usually see it past the age of 50 years, And usually distal extremities is involved rather than proximal muscle involvement. And it is usually asymmetrical. And you won't have this sort of perivascular endomysial inflammation in inclusion body myositis once you go for this muscle biopsy, but rather there will be vacuolated cells or inclusions inside these muscle fibrils. High muscle enzyme, CPK, Elevated ESR and CRP in 50% of the patients, not important neither for diagnosis, neither for assessing the effectiveness of your treatment, and positive ANA in 50 to 80% of the patients. Now, autoantibodies. Autoantibodies really, they are not very important in making the diagnosis. They are there, autoantibodies, because one of the antibodies, that is anti-RNP, it is very, very important, and it is a diagnostic criteria of MCTD, that is mixed connective tissue disease, or anti-PMSCL, that is overlap syndrome. Anti-PMSCL is systemic sclerosis with polymyositis. Myositis-specific antibodies are obviously there, but really they are cumbersome to do, and the patients usually they don't afford to go with this anti-JO1 antibodies. This is part of anti-synthetase antibodies. And this, if anti-JO is present, then usually the patients, they have fever, they have arthritis, they have joint pains, diffuse joint pains, and the hands are what we call it mechanic's hand. There is thickening and hardening of the radial side of the fingers. Anti-SRP, again, this is myositis-specific antibodies, and anti-M2. Anti-JO1 is seen in only 20 to 30% of the patients, anti-SRP 5%, and anti-M. So since they are very, very costly, so we usually, but if you are applying, if you are going for this ENA profile, that is extended profile of this antibodies, that you may have this anti-JO1, but absence of anti-JO1 may not refer you from your basic diagnosis once the CPK level and aldolase level are raised in a patient, so compatible signs and symptoms of polymyositis. Treatment. Now here you see the steroids. These are the main treatment of this polymyositis. Steroid you have to use in the form of prednisolone, 1 milligram per kg body weight for at least 6 to 8 weeks. If the patient is responding, then it is good. Then you have to taper the drug. But if the patient is not responding, or if the patient is displaying some sort of untoward side effects, then you have to proceed with this immunosuppressive agents, that is like methotrexate, azathioprine, cyclophosphamide, Celsep, that is mycophenolate mofetil, immunomodulatory agents, especially in the form of IVIG and plasmapheresis. Now, this IVIG and plasmapheresis we usually use in cases in which there is really a troublesome effect of this polymyositis, say like in conditions when there is respiratory compromise, secondary diaphragmatic involvement. IVIG and plasmapheresis, usually 1 gram per kg body weight for 3 to 5 days. And rehabilitation is very, very important. You have to educate, you have to counsel, you have to send your patient to the physiotherapist. Same thing more or less. Rituximab is relatively a new addition in treatment of this polymyositis. It is available here. We are using this rituximab and tumor necrosis factor, that is etanercept. Etanercept is again used in cases of rheumatoid arthritis and infliximab. These drugs are available here, that is rituximab, etanercept, and others. Nursing management is very important. That is how to cope and support your patients once they want to be able to move. Educate about the illness and balance, rest, and exercise. This is very, very important. Now, the last part of our with the skin rash, very typical skin rash. You'll see from a distance, probably you will recognize that you are dealing with a patient with dermatomyositis. It would be a bit easy for you, but you can easily overlook if the rash is at very limited place. Then you can easily overlook this dermatomyositis. You can misdiagnose as some allergic rash or some drug eruption. It is a type of inflammatory myopathy, 5 to 15% adult over age of 40 to 60 years. Again, here the women are more frequently affected. Polymyositis is a similar condition, but the symptoms occur without a skin rash. Now here, polymyositis, sometimes they are used interchangeably. When you come across a patient in whom the rash is more predominant, with little or no involvement of the muscles, with little or no muscle weakness, then your diagnosis is dermatomyositis, because here the skin in the form of rash is there, and myositis is also there, but it is not prominent. You are seeing a patient in which there is more skin involvement without any muscle involvement. It will be called as dermatomyositis, sinomyositis, that there is dermatositis basically, but the word is used dermatomyositis, sinomyositis. That is, muscles are not in, only the skin is involved. But with the passage of time, it happened that probably the muscles will be involved to complete this clinical scenario of dermatomyositis. Symptoms, they are dysphagia. Again, with the involvement of the proximal esophagus. Muscle weakness, stiffness, or soreness. Purple or violet colored upper eyelids. Now, this is very, very important sign of dermatomyositis. Purple red skin, violaceous rash, and shortness of breath. Shortness of breath is secondary to involvement of the lungs, lung parenchyma in the form of restrictive lung disease or interstitial lung disease. The muscle weakness may appear suddenly or develop slowly over weeks or months. The rash may appear over the face, over the knuckles, neck, shoulders, upper chest, and back. Now here you see purple violetish plaques. The appearance of this purple plaques in the knees may be associated with dermatomyositis. Now this may be easily overlooked. If you won't disclose your patients, this will be overlooked. Here, the classical rash is very, very mimicking to that of SLE rash. That is the malar distribution. But here, it is more not confined to the malar area just. Here also the chins, the bridge of the nose is affected. Both the cheeks, they get affected. The rash is named after the tendency of the plants to go towards the sun. That is heliotropic rash. It is very, very photosensitive. You have to avoid sun exposure to this area, and it is characteristic of dermatomyositis. So if you are seeing faces like this, 2 or 3 important differentials, very important differentials, and never forget this thing. Number 1 is SLE. Number 2 is dermatomyositis. Number 3 is, if you are encountering the patients of this, malar rash could be secondary to pregnancy. And the other differential diagnosis, maybe your patient is alcoholic, maybe your patient might be having some sort of heart involvement in the form of mitral stenosis, or maybe nothing. He may be just air-bitten. He may come from the northern areas, having faces like this. So these are some important differentials of this sort of faces here. Now, red thickened scaly skin over the knuckles. Now, this is nothing. Gordon's papules and Gordon's sign, nothing but dermatomyositis. That is very classical over the knuckles of this, over the DIP, over the proximal interphalangeal joints, and terminal or distal interphalangeal joints. This is red thickened scaly skin. Here, heliotrope eyelids, rash, classical. It is more hyperpigmented in blacks. It is more violaceous and more dusky colored in whites. You get heliotrope eyelids, and the Gottron's papules on the knuckles are characteristic by the pathognomic findings of dermatomyositis. Here you see, again here is rash, V sign, neck V sign or shawl sign. You see rash here on the face, on the back of the shoulders probably. This is shawl sign or neck V sign of dermatomyositis. Here, violet colored inflammation, erythema over the knuckles. What to say, Gordon's papules. Important signs. Knuckles, important sign. This is and very prominent here. Here you see, again, same thing. Reddish spots over the knuckles, pinkish spots. Very good. So once you see the most important, obviously, your immediate diagnosis would be of dermatomyositis. Now, how you're going to investigate? Again, here the CPK and aldolase level will be raised. You have to have with ECG. Now, why ECG? Because again here, the heart is also involved. You have to go with electromyography. Electromyography not to diagnose skin rashes, but to diagnose the myositis, myopathic pattern on electromyography. Most of the time, dermatomyositis is associated with some sort of, to a certain extent, at least muscle weakness will be there, MRI and muscle biopsy. One more thing, since in adults, if you are seeing a patient with dermatomyositis, one of the in one of our classification, myositis, dermatomyositis associated with malignancy. So you have to be very much careful, and you have to have this very thorough screening to see for any occult cancer. The cancer which are really very important is the ovarian, lung, stomach, and this breast, again, non-Hodgkin's lymphoma, very important, and colorectal carcinoma. So you have to have this cancer biomarkers like CA19-9, CA125, other things. And you have to do for this CT scan of chest, abdomen, and pelvis to rule out any occult malignancy, because the prognosis is bad once the patient come across with dermatomyositis with malignancy. Prognosis is bad. Once you treat the malignancy, the rash and the weakness will disappear. Treatment steroids are the mainstay of treatment in dermatomyositis. Immunosuppressants, however, most people take prednisolone indefinitely. And unfortunately, the side effects are again there with prednisolone, like that of hypertension, like that of diabetes, like again muscle weakness, secondary to this steroids, more muscle weakness, cataract, and osteoporosis. If the condition associated with the tumor, the muscle weakness and rash may improve when the tumor is removed. The outlook, prognosis. Some recover and have symptoms completely disappear, especially in children. But in adults, the death may result from severe and prolonged muscle weakness. Now you see here, the rashes haven't increased any mortality in your patients of this dermatomyositis. But the death is due to prolonged muscle weakness, mainly of respiratory muscles, leading to pneumonia, aspiration pneumonia, or lung failure. The major causes of death are cancer if they are not detected and not diagnosed in time, and lung diseases. Possible complications are acute renal failure, cancer, inflammation of the heart, that is myocarditis and cardiomyopathies, joint pains, arthritis, and lung diseases. Now, poly and dermatomyositis associated with malignancy and associated neoplasms are usually seen in polymyositis. It is 10%, but in dermatomyositis it's 15%. And it is more important as the age advances. So you have to be very thorough investigations to find out any occult cancer. Routine screening in dermatomyositis is mandatory. If a patient is having purely polymyositis, the probability of malignancy would be less. But in dermatomyositis, the chances of hidden malignancy is more. Thank you. पर्सनल स्पेस है, पर्सनल स्पेस चैट आया ना, चैट में आया तो ये है ना सब है। हाँ, या पढ़ ले बाकी। So your voice not clear. चलो चलिए शुरू का होगा, ये शुरू का है, ये बात पे आ गया था उधर।